Oh, yeah. Oh, yes, indeed. It is 5 o'clock on the Gulf Coast, which means there is only one place that you're supposed to be, and that is right here. It's Fertility with Fink. Good evening. Tuesday night, we are here as we are every week at this time. It's Fertility with Fink. I'm Dr. Randy Fink, live from Pensacola, Florida, where I am a fertility gynecologist here at New Life Fertility. And we get together every Tuesday at this time, 6 o'clock on the East Coast, 4 o'clock in the mountains, and 3 on the West to talk about all those things that are important in our world. And that's women's health, that's getting pregnant, that's staying pregnant, that's the fertility business at hand. We talk about sperm, we talk about uteruses, we talk about vaginas, we talk about pap smears, all those things we talk about. And yup, we're going to talk about them tonight. Hey, so glad to see everybody, and hope it's been a great week so far, and that your Halloween was a good one. I hope you got to dress up. I hope you had a lot of kids come to your house. It's actually kind of disappointing that in my house I had exactly two kids, two come for Halloween, and what a disappointment. I was really hoping to have had a lot more than that, because it's a special time. Remember back to when you were little, and you dress up and you get to go, neighbor to neighbor, and come back with pounds of candy. My kids, they went to other neighborhoods, but they weighed theirs, and anywhere from 4 to 6.5 pounds of candy is what they brought home, and that does seem to last them for a while. But we all have a little high blood sugar around my house at this time of year. But it was a nice weekend. I'm not so sure about this daylight savings thing, because it just doesn't work for me. I'm still kind of feeling a little out of it from that. And one day I think maybe we will get rid of it. But for now, we just kind of have to deal, don't we? So hello to Zenny. Hello to my dear mom and dad, Bama Gal in Mobile. Jazzy Poo, good evening. Hi, Melissa. Noodles for Life. Hello, nice to see you. Nina Thompson, you were my first to join here on my Instagram. We also have New Life Fertility's Instagram right here. Good evening to Amber in Gulf Shores. Hi to Angela. And looks like FW Beg, FW, I think that says FW Beg. Angela, it's great to see you. As always, we have also LinkedIn, we have YouTube, we have Facebook right here, and I can see we've got a few people who have joined, but they haven't said hello just yet. So welcome. If you have a question or something that you'd like to talk about, this is the place to do it. Happy to answer your questions and talk about what's going on in your world. Let's see what else we have here. It's the weather's been so pleasant here. It's been what is it outside? 64 degrees outside now. I think we had a high of about 70 here today, but crystal clear outside. Just a beautiful day, kind of dry and cool. And this is the time of year that you live for. I remember, Halloween time always being a little crisp, a little cool in the air. And that was something that was just, really kind of worthy of treasuring. I had, by the way, if you can't get a question in here with us tonight, or you don't feel comfortable asking, that's okay. You can do it anonymously as well, and do that by emailing me at askfertilitywithfink@firstfertility.com. That's askfertilitywithfink at firstfertility.com. And I got a question. I got a couple of questions here from last time. And the first was, can you explain the difference between a fresh transfer and a frozen transfer? And what about a medicated cycle versus a natural cycle? So yes, indeed. A fresh embryo transfer is after you've done IVF. Eggs come from the ovaries. They go to the laboratory. A single sperm is placed inside each egg, and that creates an embryo. So usually we grow those embryos up to some stage. If we were to take that embryo and place it back inside of you, the very same cycle that embryo was born, which would be the same cycle that you did your egg retrieval, that's what's known as a fresh transfer. If we were to then grow that embryo up and freeze the embryo, that is, stop it in time right there, then it allows your body to recover and you come back in a different cycle in order to place that embryo back inside. So that's really what we talk about with a fresh versus a frozen transfer. Now, there are some programs that will not do fresh transfers because the success rate with a fresh transfer is much lower than that with a frozen embryo transfer. And as we often talk about, that's counterintuitive to some people. Many people think that, gosh, fresh must be better, right? Because fresh vegetables are a better thing in the store, much better than frozen vegetables. So why wouldn't a fresh transfer be better than if you freeze an embryo, isn't that harming the embryo? No, it doesn't. The survival rate from thawing an embryo, freezing and thawing an embryo is really above 99%. It's very, very good. The technology that's used, and that's called vitrification, to vitrify an embryo or to freeze, cryopreserve an embryo, has really come a very, very long way. But the truth is, with a fresh transfer, your body has really been in egg making mode. Your body has really been trying very hard to make eggs such that it may not be such a hospitable place for an embryo to implant. And that's the truth with a fresh transfer. So, excuse me, generally speaking, across the board, we say that the success rates of a fresh embryo transfer are always going to be lower than the success rates from a frozen embryo transfer. Success with a fresh transfer is always lower than that of a frozen. Now, there are some options when we do a frozen embryo transfer. You can do a medicated cycle, or you can do some form of a natural cycle. And let's talk about really what that means. In a medicated cycle, we're giving you the medication. We are giving you the hormone that is, in fact, stopping your body from producing the hormone because we want to control every aspect of your hormones. We don't want to leave anything to chance. We want there to be no variability. We want to control it so that we can make everything happen ideally. And that's what happens in a medicated cycle. You get some estrogen. That estrogen builds up your uterine lining to make a nice, spongy, warm, juicy place for an embryo to implant. Then we start you on some progesterone. Progesterone pro-gestation, pro-pregnancy. Progesterone is really the hormone that keeps that pregnancy going. And what it does is that it compacts the endometrium. It compacts it down so that that it is really truly ready to receive an embryo and to allow that embryo to grow. The lining of the uterus, the endometrium, starts to change appearance that we can see when we look with an ultrasound. So we control all that stuff. Usually with a medicated cycle, we're using progesterone in oil, which is the injection. And that can be done in a couple of different ways. It can be done, usually we like to give you both an injection of the medication and some vaginal progesterone. Now, vaginal progesterone alone has been shown not to be as good. Like, it really cuts the pregnancy rates in half. We don't want to give you just vaginal progesterone, but a little extra vaginal progesterone puts the progesterone really where it needs to be, which is at the lining of the uterus. But really, you need that progesterone in your entire body, and that's why we do the injection. That injection can be done daily. It can be done every 3 days, a couple of different recipes, different ways to do that. Now, with a natural or a modified natural embryo transfer, we are letting your own hormones take the front seat in terms of making that pregnancy happen. So in a natural cycle, if you have regular monthly periods, your body's doing what it's supposed to do to get pregnant anyway. And that is that you're making some estrogen. And that estrogen is going to build up your lining, just like the estrogen that we give you is going to do. That's coming from a follicle in the ovary. That's coming from a little egg that's trying to grow in the ovary, and that one that is going to end up getting released or ovulated. That's your dominant follicle. Well, once we get to that dominant follicle and it's time to release that egg, when it gets released, your little estrogen making factory there changes over. It changes personnel and it becomes a progesterone making factory. And that's called a corpus luteum. That corpus luteum is what makes the progesterone in your ovaries. And so in that sense, you're making your own estrogen, you're making your own progesterone. And the two are really, in most cases, at least equivalent when it comes to outcomes. So as it pertains to, getting a positive pregnancy test and a live birth, they're pretty similar. So we can give you a little extra medication sometimes, and that's a modified natural, just to make sure that your ovary is going to release at least one egg, and we can trigger that ovulation. There may be some downsides to doing a natural or a modified natural, and that is that, well, you're kind of dependent on how your ovary responds in terms of making that egg. And as it turns out, well, your clinic may not be doing embryo transfers on a Sunday. And if it turns out that your ovulation happens such that your day of transfer would be on the Sunday, it means that, oh gosh, your cycle got canceled. Most of the time you can work your way around that. But nevertheless, that's kind of one of the things that can happen there. But that's the difference between a medicated versus a natural cycle. So let's see, we got some questions rolling in here. And Angela says, if you have 6 follicles, let's see, if you have 6 follicles, 16 millimeters, 19 millimeters, and one grew up to 33, would that 33 be a bad egg? What a bad egg. No, it's not a bad egg. And don't say that, because then you give it a complex. It comes out thinking, I was bad. No, it's not that it's a bad egg. In all probability, actually, Angela, that follicle probably doesn't have an egg in it. In most cases, when you see that kind of discrepancy in size, that little follicle is what we would commonly call a cyst, meaning to say that it's got the fluid in it, it's got the little cells that line it, but there's probably not an egg in it. If there is an egg in there, it's likely to become over mature, or it may have disintegrated or something like that. But usually with that larger egg, it's not that it's a bad egg, and it's not that there's some terrible problem with that. It's just that it probably will not turn out to be useful. She says, I guess the 33 was a lead follicle that was 19 millimeters on day 4 of stim. Yeah, so that was, again, probably a little follicle that started to grow. It grew very rapidly. It just didn't have an egg, but the other ones sound like they're pretty good. And here's this comes from Melissa. 2 questions here. An FET was on Friday, Halloween day, 10/31. Midway Labs today, 27. Let's see. 127. Oh, I see. I think you said preg, and I think you meant progesterone. Your progesterone is 27, and your estrogen is 126. So I think that is just fine. Now that progesterone level probably doesn't really matter all that much. A lot of times we places will test it, but truly it doesn't have a lot of correlation. Because the lining is really what's more important. The progesterone level is important. And so if you did a medicated cycle, we're looking for that progesterone level to be about a 20 or higher. And if you did a natural cycle, usually we'd like that to be about a 10 or higher. So I would say your numbers are really good there, Melissa. That is awesome. So fingers crossed. And she says, what are your thoughts about being outside in the cold for hours after an FET, sitting in a deer stand? Now that, I must say, is the first time I have ever been asked the question, is it okay to sit in a deer stand after an embryo transfer? And I would say, yes, I think it's fine. I usually tell people, look, we don't want you to do, really strenuous stuff. I wouldn't want you to keep climbing up and down the tree. even though that's not significantly different than, walking up steps, which is fine. I say, no, if I've done your transfer before, you may have heard me say, no alligator wrestling, no extreme snowboarding, no helicopter skiing. What else? No bungee jumping, skydiving. You want to hold off those things for a few days. Sitting up in a deer stand is probably okay. And the cold shouldn't bother you because guess what? Your internal core temperature stays very constant. That's one of the things that we're pretty good at as humans, and that's maintaining a core temperature, unless you're outside for a really prolonged period of time, without a coat, that sort of thing, or if you're immersed in water, hypothermia really starts to be a problem. But nope, under normal circumstances, I hope you enjoyed your time in the deer stand. And I will say this one goes down in the record books as the first time anyone has asked me, can I sit in a deer stand after an embryo transfer? I hope it was a pretty day for you, at least, because you got a little something out of that. A little extra something from nature, right? Let's see who else we have going on here. Zenny says, happy Tuesday, and the same to you. Hi to Roxy. Hey to Shelly. Noodles says, never had endometriosis symptoms, but I got a positive BCL6 diagnosis. The doctor suggests 60 days of Orilissa. Is adding letrozole better, or is there no difference? All right, so the most common, let's put it this way, the commonly known symptoms of endometriosis are pain with a period, pain with a bowel movement sometimes, and pain with intercourse sometimes. That's the most common situation. And endometriosis, we know, is the cause of a pain syndrome. However, those are the common symptoms, but the most common presentation of endometriosis is actually people who have silent endometriosis. And that is that you didn't know you had it until somebody went and took a look, or you did a test and found that your BCL6 marker was positive. That BCL6 thing is an inflammatory marker in the lining of the uterus that prevents pregnancies from implanting. We believe that this is one of the ways that endometriosis interferes with pregnancy. So it can cause scarring inside your peritoneum, inside your abdominal cavity, which can result in changing of the anatomy, altering of the anatomy. It can cause some mechanical things there. It can impact the way the brain is talking to the organs. It can change sort of the electrical circuitry that is keeping the brain talking to things like the ovaries and the uterus. But specifically as it pertains to a pregnancy implanting, the positive marker for endometriosis in that lining can prevent a pregnancy from implanting. And we know this because if we took a euploid embryo or a chromosomally normal embryo, that embryo ought to give you about a 65% probability of a pregnancy, unless your BCL6 is positive. And if your BCL6 is positive, that 65% number drops down to about 10%, unless you treat it. And if you treat it, just like your doctor said there, Noodles, 60 days of suppression with either Lupron or Orilissa or Myfembree. This is shutting off the hormonal supply to that endometriosis, particularly at the level of the uterine lining. It reboots that lining, and then your success rate goes right back up to where it was if you never had that BCL6 thing at all. So very good thing to know that you have it. And yes, you want to treat it for 60 days. The question is, should you add letrozole? So the Orilissa or the Lupron, what it's doing is that it's working at the level of the pituitary gland in the brain to shut down the way the brain is telling the ovaries to make estrogen. And that is the principal source of estrogen in your body. However, there is a secondary source of estrogen in a woman's body, and that is a conversion of estrogen that happens in our fat cells. And that's where testosterone is converted into estrogen. And that has a name that's called, that chemical reaction is called aromatization. Like, oh, it stinks, but I'm not sure what the connection is there. But so letrozole is a medication that is called an aromatase inhibitor, and it stops that conversion of estrogen in the fat cells. So there is some evidence that shows when we stop the conversion of estrogen in the fat cells, that the outcomes may improve a little bit. So really the question is, if you're shutting off both your central supply of estrogen, which is brain talking to ovary, and you're shutting off all the estrogen that arises peripherally in your fat cells, you can imagine that you may have more symptoms of that kind of estrogen deficiency, right? Because you're shutting off all sources of estrogen. Is the marginal improvement that you get from using letrozole with one of the systemic suppression medications worth the extra side effects that you get from taking the letrozole? I'll leave that to you to decide. So I will say, yes, there is evidence that there's marginal improvement in the outcomes when you use letrozole with that suppression, but it's not huge. So the suppression alone is probably adequate. I think it may also depend on sort of what's the burden of the fat cells. So in a woman who may be obese, I would say there's probably some benefit to using the extra letrozole, because there might be more fat cells involved that can convert more estrogen. And in that scenario, it may be more beneficial. So it's usually a conversation that I'll have with people so we can sort of weigh out the pluses and minuses, the benefits versus the risks. And what's the risk? Well, you're on it short term. It's only 60 days anyway. But during that 60 days, you may just not feel great because you're really temporarily being put into a menopausal state. So that's really kind of the thing. Hey, Timmy, if you're watching tonight, hi, Marie, good to see you. Roxy Clay says, thank you for your live videos. It is my pleasure. I learned a lot. Finally, I have my baby boy, almost 2 months now. Great work you do. I followed you since CNY. Roxy, that is awesome. Thank you so much for sharing and saying that with me. And please, you know what, if you would send me a picture of your baby, because I would love to post it. And by the way, if I have been involved with your baby at all, please send me a picture, because I really want to share with the world how lucky I am to have had you in my life, and that we have some other lives to show for that. Amber says, do you ever want to open your own fertility clinic? Well, one never knows. One never knows. Let's see. Marie says, can you conceive naturally after 2 to 3 months of suppression with Orlissa? I'm 36. I have stage 4 endometriosis, diagnosed with a laparoscopy in June. I had an unsuccessful retrieval since, in other words, 2 aneuploid embryos. So can you conceive naturally? Absolutely, you can. It kind of depends on what the nature of the fertility problems were to begin with. And, kind of here's an important thing to know, Marie, because there are people who come to me, I hear it all the time, who say, they told me I would never get pregnant. They told me I would never be pregnant. It's never going to happen. And I would say, gosh, I will never tell someone that they will never be pregnant. If you remove your fallopian tubes, okay, that makes it a lot harder to get pregnant. But we see people who have, let's say we have a male factor. They've done a semen analysis, and it comes back as what we know of as azoospermia, meaning there is no sperm in the specimen at all. That they spend hours looking at those slides trying to find sperm in his ejaculate, and there's none there. And we say that's going to be really hard, because if there's no sperm, there's nothing to fertilize. Well, wouldn't you know it? Some of these people will, a month or 2 or 3 later, come back and they're pregnant. And you're like, where in the hell did that come from? And it didn't come from the UPS guy or the mailman, it came from the husband. And you know, there's just no absolutes in the world. They spent 4 hours looking at the semen analysis and couldn't find any sperm. But how many sperm does it take to fertilize an egg? One single sperm. So if one sperm can get out, it can do the job. Trust me on that one. Yes, it absolutely can. So can you conceive? Yes, you can. You know, there are some people who don't ovulate. And if you don't ovulate, well, at some point you may ovulate and it's going to surprise you. And you may just happen to have sperm there. Remember, sperm lives inside of you for 5 days. And you know, 85% of couples will conceive within a year under natural, normal circumstances. So yes, you definitely could. There's nothing about endometriosis that necessarily that permanently blocks people from getting pregnant, you know. Let's see. What if the only way to get your lining thick is vaginal estradiol, but it makes my estrogen levels get very, very high? Couldn't that level negatively affect your transfer? Yes, it could. Yes, it could. Because if the level's that high, you know, ideally, we'd really like to see those estrogen levels for transfer anywhere, let's say between about 2 and 700 is probably optimum. So, Angela, I would think that there might be some use for something like PRP, that's platelet-rich plasma in your endometrium to try to boost it up and to be able to grow some without, or to sensitize your receptors to estrogen so that your lining grows a little bit better. So yeah, I don't love to see those kinds of numbers for embryo transfer. Hi, Styles family. Oh my goodness, Angelina Foxy is here from the great north. I guess that's considered northwest Minnesota. I think so. Hi, lovely Onyx. Haley, good to see you this evening. Hi, Lexi. I hope you're doing well and that everything is nice and stable in your world. And I think you know what I mean there. Sun and Fun. Hello. Hi, Ruger. Hey, Liz. Let's see. Before we go any further, let me just say it's 5:30. So you know what time it is now. It is time for the 5:30 Fuzzies with Fink. And what are these 5:30 Fuzzies with Fink? And I hope that we can really max out here the number of people that we have on board. Look, the 5:30 time is when we can all get together for just a moment and take a moment to really reflect on what we're doing here. I know what I'm doing here. I'm doing this because I love helping people. I love helping people get pregnant. And I think that every single one of you who is watching this broadcast would pretty much do anything to help somebody else who is going through a similar situation as you. It's nice to know that you and your heart and your mind and your situation is being thought of and sent good vibes by somebody else. And that's what we're doing here. And it's not just fertility. It's about relationships, because they're hard, aren't they? It's about workplace. It's about life in general. It's about all of those stresses we have out there. This is our chance for each of us to get together, to join hands, and as one community stand together and send those good wishes out there to everybody who needs it. If you're alone, if you're lonely, if you're worried, if you're scared, know that we are here for you, that we are all thinking of you, and that we are all in this thing together. And that's going to G172, to Plant Honeys, to Zenny, to Angela, to Melissa, to Sheila, to Adge. This is going to Harold and Emily. This is going to Amber. This is going to Liz and Marie and Bryn and Baby Love and Lexi. Especially to you, Lexi. 8 weeks today. That is amazing. We are all here with you. Ruger and Angela and Roxy, Timmy, if you're still around, Noodles, Shelly, who else we got here? Jazzy Poo and Nina Thompson, if you're still with us here on the program. This is the time that we say our hearts are there for each other. Let's do this together. We can get through it no matter how hard it is. And that, my friends, is the 5:30 Fuzzies with Fink. Thank you for being a part of that. And please, next week, get all your friends to join, even if it's at 5:29 until 5:31, because I really think that the more people that we have here to be able to spread that good news and just to kind of be a part of the community here, the more we have, the merrier. That's the Fuzzies with Fink. Thanks so much. So Lexi, getting back to you, my friend, man, I am so excited. So Lexi had, hope you don't mind me sharing, had a little scare there up in the Carolinas, and that was she had an early ultrasound done, and I believe that it was right around the 6-week mark, and they thought that they found that she was a little earlier than she thought, and they didn't see anything. And so that gave quite a scare to wonder what was going on there. And what we learned from that is that ultrasound is not a perfect thing. And we look at ultrasounds because we think it's going to be perfect. That if we can see it by ultrasound, the ultrasound measurements are going to be the most accurate we can get. Ultrasound can be off by 5 to 7 days in the first trimester, by up to 2 weeks in the second trimester, and even up to 3 weeks off in its prediction of size by the time we're in that third trimester. And so as you get more and more pregnant, you will find, so let's say that you're pregnant and then you go and you do an anatomy ultrasound, which is usually done around, let's say 19 weeks, anywhere from 17 to 20 weeks pregnancy. You may find that that the measurements they take are off, that they're not consistent with how pregnant you actually are. And they may say that, based on that, due date is expected as something that's different from what you found early on. The earlier your dating criteria is, the better off it is, the more accurate it is. As you get more pregnant, the due date does not change. The accuracy of the measurements change. It becomes less and less accurate. And that's something a lot of people didn't know. But Lexi, I'm so happy, and I am so glad that you are, only saw a sac on the first ultrasound, and then a yolk, a fetal pole, and a heartbeat a week later. And I hope that you are going to be nauseated as hell, because that's a good thing, right? And I mean that in the nicest of ways. Bryn asks, do you think Neupogen shots and love truly made a difference into my success, or just a normal embryo? Debating for next transfer since Neupogen is so expensive. I see. Neupogen shots and Lovenox, I think, is probably what you meant, because I'm thinking, did love make a difference here? I think it probably did. What a beautiful sentiment. Love always makes a difference, Bryn. I think it really depends on the situation. And there is not a lot of great evidence that Neupogen in the general population does make a difference for embryo transfer. There are some very specific populations that I would think of Neupogen for, and they are fortunately few and far between. So to be honest with you, I really don't, it's hard for me to say, well, not knowing all your history, I can't make, a truly educated guess, but I would say that if you did without Neupogen, I doubt statistically that you would be harming your pregnancy. And I base this on the fact that there are some practices that will prescribe a very robust immune protocol for every single patient, despite the fact that the American Society for Reproductive Medicine says, don't do that. It's not necessary. It's exposing people to potentially, to medications that may have some issues with them. And they're not all benign medications. And so, and certainly Neupogen's really expensive. So, I'd say I'm really plus minus on that. Lovenox too, the real indication for Lovenox is specifically for people who have something in their blood that's causing that blood to clot. And that's a test for what's known as a thrombophilia. Thrombo to clot, aphilia means it has an affiliation for it. So your blood likes to clot because of some factor in your blood there. Um, uh, if you've been tested for that, and that usually arises in people who have had recurrent pregnancy losses, or in a situation where people's family history suggests they may have a clotting disorder, and that's people who've had blood clots in the legs or the lungs, and that's one of the questions that we always kind of ask folks. Those people need Lovenox. Other people, a baby aspirin really probably suffices. That Lovenox is really probably not something that's necessary. Now, in some cases, we will use Lovenox just empirically, and that is, well, maybe you've had a bunch of pregnancy losses, you never had those tests, but we're really convinced that something may be going on there. So you can use Lovenox. It stings. It leaves you bruises. It's a bunch of shots, more shots you have to get, when really, truly in that scenario, it may be that a baby aspirin does really just as fine, Brent. So I don't feel as strongly about those things really as I once did. Midgie asks, can you recommend an alternative to prednisone? So prednisone is a steroid, and it's something that we sometimes give to patients, particularly for an embryo transfer. Now, again, some practices use it in egg retrieval, but the evidence isn't so good for it in egg retrieval. But specifically for embryo transfer, you can think, well, I'd really like to kind of try to suppress some of the immune response I might be having that may be standing in the way of a pregnancy. Do I think it's appropriate for everyone? No, I don't think it's necessary for everyone in an embryo transfer cycle. What else could you do? Well, there are other somewhat, really benign medications. We've talked here before about low-dose naltrexone. Low-dose naltrexone blocks the opiate receptors, or some of the opiate receptors in your brain, that then results in a reflex increase in your endorphin levels. Endorphins are the feel-good chemicals in your body. So an increase in those feel-good chemicals actually results in a boost to your immune system. And not a boost in a bad way. It shuts down the bad parts of the immune system and really fires up the good parts of the immune system. So if you don't want to take prednisone, and there's not a specific reason that you're taking prednisone, and I say that because sometimes there are specific reasons that we give you prednisone, but if it's just because, well, we give it to everybody, I would say low-dose naltrexone is a very, very good alternative to suppressing some of the immune things and boosting the ones that you want and suppressing the ones that you don't. And it doesn't have any of the side effects. Prednisone is not a benign medication. I've said that before. Prednisone causes you to gain weight. You retain water. Your blood sugar gets higher. It affects your adrenal glands. It can cause osteoporosis over the long term. So, and a lot of times people end up on their prednisone, and two things happen. One, the practice forgets to stop you on it, and the next thing you know, you've been on it for 6 months. Or sometimes they'll say, okay, you can go ahead and stop it. They didn't really give you good instructions, and you just stop it. And really, you shouldn't just stop prednisone. You should taper off your prednisone, because otherwise it can hurt you and it can make you really sick and make it not feel so good. A lot of times when you start taking prednisone, you may feel good in the beginning with that steroid, but then it starts to wear on you, and you may not feel so good after a while. So I am selective about those in whom I use prednisone. But low-dose naltrexone, if you're not taking that prednisone for a specific reason, low-dose naltrexone may be another good option for you. Thanks for that question there, Midgie. Haley asks, do you suggest starting at 4.5 milligrams of low-dose naltrexone, or starting lower and slowly increasing? And that's an excellent question, because I used to, when I would use low-dose naltrexone, for example, to treat chronic pain in situations like known endometriosis, I would usually start low at like 1.5 milligrams. And then after a couple of weeks, increase it to 3 milligrams. And then after a couple of weeks, increase it by another 1.5 to 4.5 milligrams. So I would work my way up, titrating your way up. Well, it turns out that, is that really just kind of delaying it? Most people really don't have a lot of side effects from low-dose naltrexone. So you take it in the evening, you take it at night because it can make you sleepy. But what happens when you raise your endorphins? Some people get interesting, let's call them interesting dreams. And by those, I mean some really like horny dreams. And, if that's the worst side effect that you're going to get, that you're going to have horny dreams and you get sleepy at night at bedtime, I'd say, well, that's really not such a bad thing. Naltrexone in its regular dose is 50 milligrams. And so 4.5 really truly is a low dose. But if in doubt, if you feel like you're sensitive to medications or if you're worried, I don't see that there's any harm to starting at a lower dose and titrating your way up. But do you have to do that? No, I don't think that you do. Hi, Iandre. I haven't seen you for a little bit. It's always good to see your face there in G172. Howdy. Thank you for being here tonight. Let's see what else we got going on here. Plant Honey says, sorry if you already answered this, but what should the estrogen and progesterone be for a modified natural FET at transfer? So I wouldn't look for the estrogen because a modified natural, as we discussed before, is using typically letrozole to make sure that you're going to release an egg. And like we talked about with letrozole, what does it do? It lowers your estrogen level, the serum level of estrogen in your blood. And so if you're lowering that level because you've taken estrogen, estrogen is not a useful marker for anything in embryo transfer if you've lowered it with letrozole. So I encourage don't even test it. Because inevitably what happens, and I've seen this in places that I have worked before, and that is in a large sort of fertility practice where everyone doesn't have the same level of training or expertise. Maybe somebody uses letrozole. And so their estradiol level is lowered. And so they check that estradiol and they find, it's low. And so then a nurse or a medical assistant sees that and says, your estrogen is low, so we have to put you on estrogen. And then the next thing you know, you're using a bunch of estrogen. And then the next thing you know, the follicle that you were building to try to ovulate because of that natural or modified natural cycle gets suppressed because you're dumping a bunch of estrogen on it. And due to the feedback mechanism, it's killing your follicle. And then your natural cycle just became a medicated cycle. So I really don't recommend testing the estradiol there, Plant Honeys, because even without doing a modified natural, the estrogen level is really not important. What's important is what that estrogen is doing, and did that thicken your lining? Did it make it 3 layers or trilaminar, which means that it's okay to start progesterone? Or in the case of a natural cycle, you're going to ovulate anyway. So I don't look at that number. But the progesterone level that I look for in a modified natural is a 10. I'd like that to be a 10 or greater. If it's a 9.9, honestly, it's probably really the same thing. There are very few instances, unless that comes back at 6, in which case I would say, all right, now I think we need to give you some extra progesterone. But most of the time with and the point of a modified natural or a natural FET is that your body is making its own progesterone. Remember, from that corpus luteum. And if you're making your own progesterone, you don't need a shot in your butt, and your butt will thank you for that. So that's the only thing to be aware of there. So I have a very high threshold to adding progesterone in a modified natural, unless that number really is significantly below a 10. And let's see, uterine PRP did not help to thicken my lining, only the oral estradiol. Oral estradiol doesn't help either, only the vaginal estradiol. Maybe Neupogen wash can help. Neupogen absolutely can help in that scenario. So one of the indications for Neupogen is to help to build a lining in somebody who doesn't build a good one. So yep, a Neupogen wash as well as Neupogen shots. So people think of that Neupogen as something that you would use for your to boost your white blood cell count, do something for the immune system. Actually, that's its best use, and that's building up the endometrium. One other thing that you may be able to try there is that there is an injectable estrogen that's called estrogen that's used. It's very inexpensive. It's used every other day, and that's something that we can often kind of use in someone whose lining doesn't really like to grow very well. Just another kind of a thought there, things that you might try. G172 says, I just found out I have retained products of conception after 2 DNCs. Wow. Can this negatively affect fertility or make conceiving difficult? Well, gosh, so it sounds like you have been through the ringer here, and I'm just going to say that the official word on that is that really sucks. Oh, interesting. Looks like my my video on New Life Fertility's Instagram suddenly just shut itself off. I wonder why. In any event, and it left me making a very funny face there. So I don't know what happened. I got to tell you that that's really strange to still have retained products after 2 DNC. So it's bad enough to lose a pregnancy and to have a DNC, but then to have retained products and to have a second DNC, and those products of conception are still there. Wow. So what you really need there, friend, is a hysteroscopy. You really want a qualified gynecologist to place a camera inside the uterine cavity to really see where that retained product is and to selectively remove it. That is not to scrape down your whole cavity again, because that's where you run the risk of damaging it. And so I would want to be real careful with that uterine lining after a couple of DNCs in this case. You don't want to leave that tissue there. Yeah, that tissue is, it's a nidus for bad things to happen. So bacteria can get a hold of it. It can start to necrose, or your immune system can start to break it down like it's a foreign body, or it can embed in the lining of the uterus and start to, ultimately cause some damage to the otherwise, potentially normal endometrium. So a hysteroscopy, I think, is really the right way to go, to take a look inside and really only selectively remove what you have there. Gosh, I am so sorry that's happened to you, because that is really, truly a real challenge. Hi to Mimi, how you doing? That actually reminds me of another question that I got earlier, that I got sidetracked. I got a little ADHD on that and forgot to answer it. One of the questions from the email, and by the way, the email address is askfertilitywithfink@firstfertility.com. And if I can't get to your question here, or if you have an issue where you'd like to ask a question but don't feel comfortable sharing it with everybody, you can ask it anonymously and we won't identify you, but we'll take it up at the top of the show next time. And that question actually had to do with retained products of conception. And the question was, do I have to have and that's a term that we use, and I throw that term around like it's something that everybody has heard before, and I know it's not. Products of conception. What does that mean? Well, that's all those cellular parts of the pregnancy that are on the inside. And so let's say that unfortunately you have a miscarriage. what we refer to on the inside of the uterus there is the products of conception. Let's say that you pass that tissue, but you leave some behind. You don't pass it all. That is what we call retained products of conception. So the question was, do I always have to have a D&C if I've got retained products of conception? And the answer to that is no. So a D&C is a surgical procedure where we are going in to physically remove that tissue. But there's another way to potentially do it, even though it doesn't always work. Sometimes it does, and there's usually little harm to trying if you would like. And that is to use a medication that's called misoprostol. The brand name for that is Cytotec. So Cytotec or misoprostol is a medication that we can use. Let's say if you've had a miscarriage, let's say you have what we call a missed miscarriage, and that is that we've diagnosed that the pregnancy isn't continuing, but it hasn't come out yet. Well, some people prefer to wait and let nature take its course, and that's okay. Some people prefer to use a little medication vaginally, which will cause your body to then pass the contents. And that medication is called misoprostol. Some people prefer a surgical procedure, so then it's just over and done with, hopefully. But with retained products, let's say that you pass some of that tissue yourself, but then you've left some of it behind. Sometimes the medication alone is enough to be able to help you to pass that medication out. Now, by the way, in your situation there, G, I think that having had 2 D&Cs and still having retained products means I don't know that the medication itself would do it. I think, probably putting a camera in, looking to see exactly where and what that is, and then just very selectively removing that tissue is your best bet. But sometimes there is a medical way to be able to handle that miscarriage. Miscarriage, I have to say, is one of the hardest things that I have to deal with. I believe it is a harder thing to deal with than situations where people who should be getting pregnant aren't, and we have to face those very difficult conversations. To be honest with you, I'm finding it difficult to have the conversation just about miscarriage here because, it's very triggering for some people to talk about those pregnancy losses because they are members of our family. And I think we discount, or let's just say people who haven't really had to experience it, discount what it's like to suffer through that kind of loss. And that's why there are support groups for folks who have had pregnancy losses. And, you hear a lot of people out in the community say, oh, just, come on, you'll get pregnant again. Don't worry. Just put it behind you. It's a hard thing to just put behind you. It's a loss like any other loss, and it can be very significant on your life. And then to have to go through something else like passing that tissue or having to go get an IV to have a D&C, to have to get put to sleep to have a surgical procedure, or then having some tissue that's left behind, or getting an infection or something afterwards. These are challenging things in our world. These are tough things to have to deal with, and I think we have to give credit where credit is due to ourselves for dealing with them, because they're really not easy. If you have suffered through a loss, our heart goes out to you. And again, like we talked about at half past the hour, we stand together as a community in dealing with these problems and dealing with these things together, because we are really all in this together. What's up with you folks for the rest of the week? I've got a pretty quiet week here in town. Next week, for a couple of days, I will be with my colleagues at the Missouri Center for Reproductive Medicine in the St. Louis metropolitan area, and looking forward to seeing friends there, all the folks who work there, and the very kind patients up in that area. I'll be doing some retrievals up there on some of their busy days. So if you're in St. Louis or Chesterfield, Missouri, stop by and say hello. Hey, Noodles, thank you for your very kind words there. We are approaching the top of the hour here, and I hope that you will join me next week. Tuesday, I'll be back here in Pensacola, right here with you at Fertility with Fink. Questions, feel free to throw them my way, save them up for next time, or ask Fertility with Fink at firstfertility.com. Remember, folks, that this whole fertility thing is not the book of your life. It is just a chapter. And what are we doing? We are rewriting that chapter together. So until next time, every foot forward with love, every foot forward with kindness. As I say, there is not enough kindness in this world. Smile at a stranger, do something nice for somebody else, show up at 5:30 and send your good vibes to the people who need it for whatever reason out there. Be there for other folks and know every step forward with hope, because tomorrow is a new day full of all new adventures. And until then, Dr. Randy Fink here. Thanks for being with me. Good night.